delighted to moderate yet another session of none other than one of my very good friends, Dr. Pravas Mishra. When I first met him, the occasion was he came for his pre-employment checkup to be appointed at Max Sarkar. So I found very different vibes, very positive vibes with him, and introduced him that we like to make a good team. And very soon we found CME, he was a speaker and I was moderator. I have been following him for so many years and requesting him to have one more CME with our elite group, and today is another chance. I am really delighted, and I am lucky that I am back from my UK tour that I could attend his CME. I don't want to give so many lines for his introduction. He is one of us, one of very good hematologists, attached to one of the world's Asia's best hospital, and he will tell us about what is new in hematology. We had recently a hematology conference with us, with a CME with us, and there we had discussed in detail what is new about immunotherapy, some treatment for lymphomas. So hematology is upcoming. Gene therapy, gene addition, and next say translation into the genes is upcoming in the near years. So let us know from him what is new. Thank you, sir.
Good evening, everyone, and it is indeed my proud privilege to be part of this very excellent and dynamic group. And I really am thankful to Dr. Kalra sir for having introduced me to this group so many years back in 2017. So without much delay, what I am going to be talking about is advances in hematological malignancies. Sir mentioned that you have already gone through a CME. I will not go too much into the academic part. Yes, there are some slides which might look academic, but basically I'll just explain to you what it is that is new about hematology. Now, when we are talking about advances in hematological malignancies, you know that when you give chemotherapy, that traditional chemotherapy is there, where you lose your hair, you do so many things, your blood counts come low, you receive repeated blood transfusion. All the toxicity of chemotherapy is there. And you know, the patient का पहला question यही होता है कि इसका side effect क्या है. So, in hematological malignancies, we are always at the forefront. Like you know, sickle cell disease, the first disease where you had a molecular diagnosis, that was sickle cell disease, that is hematology. Targeted therapy, I will introduce it to you, hematology. Cellular therapies, hematology. Chemotherapy-free regimens for treatment of malignancies, hematology. And then we have got various molecular diagnostics which exploit all of these advances in what is called precision medicine or personalized medicine. That again is hematology. That means the hematologist first starts and then everybody else follows. There is something called chronic myeloid leukemia. You all know Philadelphia chromosome 922. That is a long arm of chromosome 9 and 22. They break from each other and they combine to form a new small chromosome 22, which is called as a Philadelphia chromosome. This forms a genetic mutation that is called BCR-ABL. This is constitutively active. It has got no further connection with the body's regulatory mechanism, and because of that there is an excessive proliferation of cells, and that is chronic myeloid leukemia. Before that, the only treatment you might all remember was hydroxyurea, Mylan, ये सब देते थे. You know, there was no actual cure to it, and most patients would die. In fact, when I started my career in hematology, one of the biggest indications for a bone marrow transplant was actually chronic myeloid leukemia. And now I hardly see any patient of chronic myeloid leukemia for transplant. Why? Because of this particular drug, called imatinib. What it does is that it just goes and sits in the ATP. ATP is the energy point, and that is where imatinib sits, and it blocks the pathway. I will not go too much into the detail. Very few drugs actually go onto the cover of Time magazine. And this drug, Gleevec, was there in 2001. That is the same year as your September 11 attacks. So that was the time when this drug was first came into the thing, and it was a magic drug. Why? Because one pill and the person is cured, and you are taking this for several years and the person is now free of the disease. Everybody started thinking that something new will come out of this, more drugs will come. This was 2001. Before even imatinib was there was another drug called Atra, that is all trans retinoic acid. Dermatologists might be using retinoic acid in their practice. There is this drug which was introduced by the Chinese in 1988, about 14 years before this imatinib. This is for a disease called acute promyelocytic leukemia. Before this drug, almost every patient of APML was being treated with chemotherapy, 70% mortality rates. After this drug came into, this is not a chemotherapeutic drug. This along with arsenic, we also use arsenic by the way, in this particular indication, 85% cure rates. That is and this particular malignancy, acute myeloid leukemia, is no longer treated with chemotherapy. Okay, so these are of course 1988, 2001 are not recent advances, but I am coming across to the recent advances. Now we have got BCA2 specific inhibitors. So we have got certain anti-apoptotic molecules in the body, which what happens to cancer is that cancerous cells are our own cells. They become cancerous and they want to stay alive for a very long period of time. So there are these apoptotic mechanisms within the body which these cancer cells then twist. They twist it so that they survive. And what this drug does, it mimics the same molecule and goes and sits there, does not allow that mutated gene to start working, and that is how the cancer cell then dies. This is called venetoclax. This is a BCL2 inhibitor, and it is like used in both myeloid and lymphoid malignancies. This is, you people might remember this from your MBBS MD times. This is the Krebs cycle, where we have got the isocitrate dehydrogenase and alpha-ketoglutarate is formed. Now there are certain malignancies, myeloid malignancies, where this IDH molecule gets mutated. So that gene which produces this IDH gets mutated, and because of that, an alternate molecule is formed, which then inhibits something called a TET2. This again stops the differentiation of normal cells into mature cells. And when the differentiation is stopped, these undifferentiated cells become malignant cells. And now we have got molecules which can target this particular molecule only. Without giving chemotherapy, you can just give this one drug, and that particular malignancy, if it has got this mutation, can be cured. So 1988 Atra, 2001 was Gleevec, and then 2014 onwards, a slew of molecules started coming into the market. So there are venetoclax and all of these drugs. I will not go into the details, but they are small molecules, and these are engineered molecules. That means you first find the mutation, and then you reverse engineer a drug which is only going to go and attack that particular mutation and nothing else in the body, and that is why much of the side effects are also reduced. That is not entirely true. We are not that perfect. Some side effects do come, but otherwise you get the picture that all the side effects of chemotherapy are not happening when you use these newer molecules which are reverse engineered just for that particular mutation. That means your patient should have the mutation for that drug to work. Because previously क्या होता था? You have acute myeloid leukemia, that same chemotherapy, one shoe fits all. Everybody was getting the same chemotherapy. But now we first find out whether your patient has got that particular mutation or not. And if that person mutation is there, then you have got all of these new molecules that you can start to use. Rheumatologists in this group will be familiar with rituximab. Rituximab is anti-CD20. It is used left, right, and center in many autoimmune conditions. Also, it is also used in malignancies. It acts against the B cell because the B cell has got the CD20. And lymphomas, you just heard that, you must have heard lymphomas have got CD20. Rituximab acts against, again, this is an old molecule. I am going to introduce the newer ones after this. So it acts against the malignant cell and causes cell death by various mechanisms. It can cause death by antibody-dependent mechanisms, by direct cell toxicity, and it can also cause death by complement-mediated cell toxicity. This is rituximab, very old drug. After that, there is a newer drug. It is also acting against CD20. It is called obinutuzumab. It is much more powerful than CD20, than the rituximab, and it lasts longer in the body, and it is also used in various conditions in lymphoma. Again, you might have heard of this drug. So we have got the type 1, that is rituximab, and type 2 is obinutuzumab. There are some differences in the way they work, but apparently the obinutuzumab is supposed to be much more powerful. Now, what happens when, cancer cells are very intelligent. Very intelligent. So, you have got a drug which is acting against CD20. What does a cancer cell do after a while? It hides that CD20. वो छुपा देता है, सेल के अंदर छुप जाता है. So these drugs will no longer work. So what to do now? So that is where this drug now comes into the play. This is called polatuzumab. This is again a monoclonal antibody in which it acts against CD79A. So now CD20 is hidden. Now you act against another antigen. So it acts against CD79A, but it is also combined with a chemotherapeutic drug that is called so it is called MAAE. It is a chemotherapeutic drug. It is an antibody drug conjugate. Okay, so this acts again, it combines to the cell and it enters the cell, and once it enters the cell, the chemotherapeutic drug breaks that cell. But at the same time, what polatuzumab also does is that it also increases it brings back the CD20 which is hidden within the cell onto the surface of the cell. So in lymphomas, they combine polatuzumab with rituximab and some amount of chemotherapy. So polatuzumab makes the cell once again sensitive to that old molecule called CD20. There are similar various kinds of antibody drug conjugates. We are using something called gemtuzumab ojogomycin that is targeted against CD33, that is in myeloid malignancies. You have got drugs against CD30, that is brentuximab, that is against Hodgkin lymphoma. And similarly, you have got inotuzumab, that is against CD22, that is in PALL. Again, these are all antibody drug conjugates where there is an antibody against the monoclonal antibody directed against the surface of the cell. It goes and sticks there and then introduces a payload. It's a kind, introduces a payload within the cell and breaks the cell. This is another drug called BTK inhibitor. This is bruton tyrosine kinase. Again, there are various drugs. This is for CLL. Now again, previously CLL ke liye all used to give again drugs like busulfan or some drugs like chlorambucil. These were what you were treating CLL with. And it was chronic lymphocytic leukemia was not obviously never cured. It is still not cured, but at least the survival is better with these new drugs which combine against certain molecular targets within the lymphoid cell. These then they break the proliferation of these cancerous cells. So these are the newer drugs that are there. As physicians, it is important to know about this particular drugs. It is important to know about these drugs because they have got certain off-target problems also. Off-target में क्या होता है? You have got these drugs like ibrutinib, which can cause atrial fibrillation. So if you have got a person with a cardiac problems, then this might not be the drug to give. If you have got somebody who is on blood thinners, then again this might not be the drug to give because again they might have certain off-target effects on platelets. So the person might have increased bleeding. So there are newer drugs like we have got ibrutinib, then you have got certain other newer drugs which can work much more selectively and cause less side effects, but it is very important to understand that these drugs can cause certain other off-target problems also. Now when you are talking of immunotherapy, you must understand that you are trying to harness the power of the immunity, your own immunity. Ultimately, what is immunotherapy? That is what it is. But when you are doing cells which are directed against B-cell directed therapy like rituximab, or you are giving obinutuzumab, or even the BTK inhibitors, this is essentially passive immunotherapy. Passive immunotherapy means you have got some antibody target, you are directly putting a monoclonal antibody and you are hoping that the cancer cell will be broken down. And then you have got certain other targeted therapies which are against CD20. So this is all passive immunotherapy. Just to refresh, these are the components of your adaptive. So when you have got an innate immunity, then you have got an adaptive immunity. Adaptive immunity are your B cells, plasma cells, memory cells, and the T cells are like your helper T cells, CD4 cells, CD8 cells, memory T cells. These are all your components of your adaptive immunity that we are looking at. And the functional components of these adaptive immunity are your antibodies like IgG, immunoglobulin A, T cell receptors, B cell receptors, MHC. These are all the functional components of this adaptive immunity. Then these are the innate immunity. Innate immunity are the first line of defense. Macrophages, neutrophils, dendritic cells, natural killer cells. So all of these things you already know. But now, in the recent advances, we have got molecules and targets which are now targeting these particular activities only. So we have got T cell, engineered T cells which can target against acute myeloid leukemia or multiple myeloma. We have got checkpoint inhibitors which can act against Hodgkin lymphoma. Allogeneic transplant, I do BMT. BMT or a bone marrow transplant is pretty much the earliest immunotherapy that we have been doing since several years. Since 50 years, this is there. It got its first Nobel Prize for Dr. Donald Thomas. Then I got donor lymphocyte infusions. For example, in patients of acute myeloid leukemia, after having done the transplant, patients can still relapse. And in that, what I do, I collect some more lymphocytes from the donor and start infusing very small quantities and boost up the person's immunity. And that will then attack the myeloid leukemia. So that is donor lymphocyte infusion. Cancer vaccines. February 25, I think Russians had said that they had got some vaccine against cancer. Every second patient who comes to my clinic knows what is this vaccine against cancer. And then we have got other new antigen specific T cells which are also in the market. What is a checkpoint inhibitor? Checkpoint inhibitors are basically small, like again I said, cancer cells are very intelligent. What it does, it makes certain checkpoint on itself which then blocks the T cell from attacking it. So what does the body's immunity do is that basically the T cells are the cells which are attacking the cancer cells. But you must also remember that these cancer cells are your own cells only. So after T cells, after hitting one or two cells, start recognizing them as their own, and that is why the cancer starts proliferating. At the same time, the cancer cells also develop some PD-L1 inhibitors. These are called checkpoint inhibitors, and they also inhibit the destruction of the cell. So you got certain drugs like nivolumab, which is useful in Hodgkin lymphoma. Various other such checkpoint inhibitors are there used in various other malignancies. I will not go into them. And then finally, we have got this natural killer cells, mesenchymal stem cells. Again, these are all experimental, but mesenchymal stromal cells we are using in bone marrow transplant to reduce the inflammation that is there in those patients. So this was the vaccine I was talking about. 2020, I think 2025. The Russians were saying they have some vaccine. They have not mentioned which particular cancer it is, but it is not like the vaccine is there for all cancers. So what they do is that you essentially have a tumor antigen which is linked to some cytokine. It is then taken up by a dendritic cell within the lab, and within the lab, then this they start stimulating the T cells, and these T cells are then introduced back into the body as peptides. So this is basically a peptide vaccine that is introduced into the body for a particular cancer, not for all cancers. As of today, there is a drug called Stimulation which is for prostate cancer. This is the only approved vaccine that is so far available in the market for any kind of malignancy. Ultimately, these are all adaptive cellular immunotherapy. Now there is a term called adoptive cellular immunotherapy. I just wanted to introduce the term adoptive. Adoptive means engineered T cells. These cells are targeted against a particular cancer. That means the immunity has already adopted a particular malignancy. So the precursor for this is what I do as a bone marrow transplant or a donor lymphocyte infusion. However, there is no engineering involved. It is rather rough. When we are talking about adoptive cellular therapy, this is defined by the National Cancer Institute. It basically says that you collect T cells from the patient's own blood and you engineer it such that it goes and attacks that particular cancer of interest. So this is adoptive, not adaptive. There are two different terms of cellular therapy. So the first one, of course, is allogenic transplant. Then you might have heard of CAR-T cell therapy. I will tell something little bit about that. There is TCR engineered cells. We have got CAR-NK cell. Then you have got virus-specific T cells which are acting against. Very important for us transplanters, particularly even solid organ transplants, when Epstein-Barr virus becomes a very big problem for us. So you have got virus-specific T cells which can be introduced. So these are all engineered T cells or the adoptive cellular immunotherapy. You might have all heard of CAR-T cell therapy, particularly in this part of Delhi. You will have people who will be very interested. They'll say, CAR-T cell क्या होता है? So people come to me for myeloid malignancy. They'll say, आप कुछ CAR-T cell therapy कर सकते हो क्या? What is this CAR-T cell? So you have got this T cell receptor. On the left hand side is your normal T cell receptor, and on the right hand side is something which is completely engineered. So what it does is that you have got this T cell at the bottom, and in this T cell one artificial receptor is introduced. Artificial receptor is introduced, it has got components. The first component on the top, this particular part here, this pink colored part with this, like cup-like mechanism, that is basically a portion of an immunoglobulin molecule. So a small portion of an immunoglobulin molecule is then combined to a transmembrane domain like CD28, that is a co-stimulatory molecule, and then you got CD3. So in nature, such a combination does not exist. This is engineered at a very molecular level, and this particular plug is introduced into the T cell. So that is why this is called as a chimeric antigen receptor. CAR is chimeric antigen receptor, and it is put into the T cell. Now this T cell is your own T cell. So what they do is that, in this part, many companies are making different kinds. Even in India, IIT are making it. There are different approaches to making it, and that is why each CAR is not the same. Previously, any molecule is made anywhere in the world, India could just copy. But now it is not, you can't just copy a CAR T cell product. Everybody has a proprietary way of making it. That particular spacer, on the left hand side you see a spacer, that is a small distance between that immunoglobulin molecule and the transmembrane domain. By just shortening it a little bit, the entire structure of the CAR T will be changed, and they will start with different. So unless you know what exact difference and size is there, you will not be able to copy a CAR T cell. You can make your own CAR T cell. The moment you make your own CAR T cell, you will have to have a trial for that. How do you make it? A given patient with a malignancy, you do leukapheresis. You collect the T cells. You send it to a company like Novartis or some other company where they do it, and there they do this T cell enrichment. They introduce certain lentiviruses which then express this CAR. They are reverse engineered to express this chimeric antigen receptor, and these are then expanded in the laboratory. They are made into a packet. So this is a drug. And this is a drug which can only act against you. For yourself, it cannot work for anybody else. It comes back to you. It takes about 2 weeks for this whole manufacturing process, and then it is introduced back into the patient's body. Now, these are being used in patients with cancers like acute lymphoblastic leukemia, like lymphoma, who have failed all particular chemotherapy and drugs. Now, these are people who will not survive. And in those group of patients, such drugs like CAR T cells are now curing nearly 40 to 50% of the cases.
Dr. Mishra, sir?
Yes, sir.
I think we are close.
We are close. Thank you. So I think with that, I just introduced a brief thing about what recent advances is there. And when we are talking about recent advances, we know there is Spider-Man. With great power comes great responsibility. Many of these drugs are extremely costly. So we have to be very wise while choosing this, and we have to be very mindful of the toxicity that could be there to physical, mental, and even financial. So this is something that is very important. Namaskar. Thank you so much, and take questions.
Dr. Mishra sir, we'll have questions and answers in the end.
Yeah.
I request my second moderator, Dr. Bhaskar Shukla, to introduce a wonderful speaker. Although I have introduced him already, but I will give it the platform to him. Dr. Bhaskar Shukla, as I introduced to you, is an eminent neurologist at PSRI Hospital, one of the most down-to-earth people you can meet in your life. He has his own center in Green Park. You can refer cases to him, and you can refer cases of movement disorders for botulinum and deep brain stimulation to Dr. Sanjay Pandey. And Dr. Bhaskar Shukla will never let you down. You ask him to give discount on consultations, you ask him to give discount on NCVs, EMGs, and on anything, he does it. And you ask to give discounts to Mr. Nishant Mehta, GM Marketing, he will go out of his way to give you discounts. Please. And Mr. Nishant Mehta has promised us that first come, first served, he will be drawing a lottery, and anyone who agrees to visit Amrita, maybe down the line somewhere in September, there is an excellent chance of winning a gold coin. Only one guy will win it. He'll be inviting 100 people there. I give it to Dr. आपका हो गया सर, आपने सेटिंग कर ली मेरा मन. I give it to Dr. Bhaskar Shukla to introduce a wonderful speaker, Dr. Sanjay Pandey sir.
Thank you, sir. I will not take much time, as sir has already introduced you. So it's an honor, still it's an honor to introduce you, sir, Dr. Sanjay Pandey sir. I will just take 1 minute. He has done his MBBS from Grant Medical College, Mumbai, and MD Medicine from IMS BHU, the prestigious institute, and done his DM neurology from SGPGI, Lucknow. And then he has also done his fellowship, 1-year fellowship in movement disorders from NIH and NIMDS. And then, and before doing the fellowship, he was already working as a faculty at GB Pant Institute. And then he joined back GB Pant Institute after completing his fellowship. And he has mentored several thesis students, I think close to 30, while his tenure at GB Pant. His academic prowess is unmatched, and he has many papers related to topics on movement disorders in national and international journals, and he has also completed Indian Registry on Movement Disorders. So, please over to you, sir. Thank you.
Thank you, Dr. Shukla, and I thank the organizer for inviting me. And I will not take much time. I will try to be short because I know we are running late. So, before I come to movement disorder, our department is providing here in field of stroke and neurointervention, comprehensive epilepsy care, cognitive neurodegeneration, neuromuscular disorders, and headache. Coming to movement disorder, I can see this is a crowd where movement disorder is more likely to happen. And if you see movement disorder, why it is movement disorder? Because everybody is making movement, and movement is necessary to survive. If you don't make any movement, you are not surviving. So movement disorder can be hypokinetic or hyperkinetic. Hypo means there is lack of movement, hyper means there is more movement. One exception is Parkinson disease, where there is slowness in the body, but there is some tremor in the hand. So it's a combination of hypo and hyper both, and that is the reason Parkinson disease is so unique. Coming to the Parkinson disease patient, so if you see the Parkinson patient, the most characteristic feature is that they become slow. Their body becomes slow, their gait becomes slow, and any patient of Parkinson disease has a combination of symptoms, like they have tremor, they have slowness, but there is another entity that is atypical Parkinsonism. And in atypical Parkinsonism, what happens that apart from slowness and tremor, patient also has repeated fall, and because of the fall, they have injury, and that is the reason that is known as atypical Parkinsonism. Another movement disorder which is very common is dystonia. So, dystonia, the patient may have frequent eye blinking, like you can see this gentleman has frequent eye blinking. There is clonic movement, like their eyes gets closed because it is making lot of movements. Some of the patients have a very repeated eye movement and they are not able to open their eyes. That is known as a clonic type of blepharospasm. Another movement disorder which is cervical dystonia. So what happens that neck goes into a very bizarre posture, like you can see these patients. So they have neck going in a different postures. And this is another patient who had anthropolis. Another dystonia is writing dystonia. So what happens that if you try to write, you are not able to write because your hand goes in a very bizarre posturing, in a dystonic posturing, and you can see that these patients do very well after botulinum toxin, which I will come later on. And you can see that after botulinum toxin injection, his writing has improved. So now coming to botulinum toxin treatment. Botulinum toxin is a poison and it is used lot in cosmetic industry, but there are a lot of therapeutic uses in movement disorder clinic. This is the Alan Scott who discovered botulinum toxin first, and I had the opportunity to meet him in 2018, and he died 2 years back, and he started injecting botulinum toxin in 1971. And so what botulinum toxin does that in because of this binding, the botulinum toxin prevents the release at the synapse, and that is the reason it produces a muscular weakness. Another way of botulinum toxin is sensory changes which it makes. Like you can see, this is a patient who had writing problem, and this writing problem is very task specific. Like this problem only happens while he is writing. This problem doesn't happen while he is eating. You can see how his hand is going in a very bizarre posturing. But it doesn't happen when he is eating. So he can eat very well without any difficulty. So eating, there is no problem. So if it is a muscular problem or it's a brain problem, then there will not be any sensory changes. So what happens that a current is being vibrated, current is being flown in the both hand, and you can see that the right hand is going in a dystonic position, not the left hand. It means that this is not only a motor problem, this is also a sensory problem. So when the botulinum toxin is injected, the patient not only have motor weakness, but they have sensory changes also. And that is the reason botulinum toxin is also effective in many painful conditions like hemifacial, like trigeminal neuralgia, like migraine patient or post-herpetic neuralgia patient. So that is the reason botulinum toxin is very, very effective in the other conditions also. So if you see the indications of botulinum toxin, it has large number of indications, and you can see that in this editorial published in Time, there were more than 700 indications for botulinum toxin. We do all EMG guided and ultrasound guided botulinum toxin injection, and this basically decreases the amount of toxin, and this decreases the side effects the patient may have. You can see this is a patient of hemifacial spasm. This is very common, and this is the patient after the botulinum toxin sees significant benefit. This is another patient. You can see is a case of oromandibular dystonia, and after injection his oromandibular dystonia is almost gone. And these patients are common patients, they are not rare patients. Now coming to deep brain stimulation. So deep brain stimulation is primarily used for Parkinson patient as well as dystonia patients also. So deep brain stimulation is basically a brain pacemaker. So what happens that we put two electrodes in the brain on the both sides, and this is connected to a battery just below the clavicle. So these are the different brain areas like globus pallidus interna, subthalamic nucleus, and in most of the Parkinson patients, the DBS is inserted into the subthalamic nucleus, and most of the dystonia patient, it is inserted into the globus pallidus. So before the DBS, we do the MRI localization, and we do some microelectrode recording, and in the OR based on the microelectrode signals, we know that the target we have reached STL or GPI wherever we are doing. And during the surgery, we can check the effect of the stimulation. Like here, you can see that the patient has a tremor, and the moment you do the stimulation, the tremor stops, and we know that we are at the right side. And when the stimulus is off, the tremor comes back again. So we know that we are at the right target, and after the surgery we do the MRI or CT just to check that we are at the right target. And after maybe 3 to 4 weeks, we start the battery on, and we do the programming. this is a patient, you can see that she is very disabling and not able to sit, not able to walk. She has lot of tremor, lot of dyskinesia, and after surgery you can see that she has been perfectly fine, doing very well. This is another patient who had lipodopainted dyskinesia, and after surgery his dyskinesia is gone and he is doing very well. This is a patient we published. She was a case of deep brain stimulation. She has a genal associated dystonia, generalized dystonia, and she underwent DBS, and after the DBS she has almost complete recovery. She is a dystonia patient who has a hand dystonia, leg dystonia, and the neck dystonia. Thank you.
Dr. Pravas, sir, please. You can be here, sir, right in front. Better lights चला दो सारे के सारे. We had two wonderful sessions, and I give it to my first moderator, Dr. M L Kalra, sir, to set the context for the first meeting, and then we'll come to the second meeting. Dr. Yeah. So please come here, Dr. Sanjay Pandey. A big hand for both our wonderful speakers. You have been such a wonderful audience today. And since we had, this was my heartfelt gratitude to Dr. J.K. Sharma sir, courtesy Dr. Sen Gupta. We wanted this to be done here in our forum, and me and Dr. Sen Gupta conspired to get a complimentary registration for all of you for Innovative Innovation Forum of India, and I'm telling you, it's going to be a wonderful conference. From my past experience, I can tell you, please register for it. I will tell you, it will be totally worth it. So, and all the topics covered, and it opens the gate to all of you to wonderful updates in medicine. To Dr. Kalra sir.
So, dear friends, you must acknowledge we had very nice two talks. One by my friend Dr. Pravas. Sir, my first chance to ask you, एक एडवर्टीजमेंट आई थी हैरिसन ताले, सिर्फ अपनी ही चाबी से खुलें, तो आजकल आपने डिजिटल लॉक्स की चाबी बना दी है. दिस इज इक्वलेंट टू QR कोड, like personalized treatment, personalized diagnosis. So I comment on this personalized treatment, like.
So this personalized treatment is of now two types. So you've got acute myeloid leukemias, acute lymphoblastic leukemias. Now you've got these molecular targets within them. If you're different myeloid leukemias will have different targets. If you have that target, then the drug will work for you. Otherwise, the drug will not work for you. If you have that particular target, you can avoid chemotherapy. Just that one drug will work. Or even if you are getting chemotherapy, you combine that particular drug with it, then you are able to respond better. That is one form of personalized medicine, where you are doing molecular tests and you are trying to find out. And the other personalized medicine is the complete other side, where the drug which is coming in the packet can only work for you and it will not work for anybody else. And that is, what we have these drugs called chimeric antigen receptors, where you have got your cancer within you. Right? And it is not working, it is not responding to anything else. And now what you are doing is, because your own T cells have stopped working against the cancer, you collect your T cells, you reverse engineer them, you put some kind of a receptor in that, and that is now working against your cancer only, it will not work against somebody else in the world. So these are the two forms of personalized medicine that we are now looking at.
You mentioned about innate immunity and passive immunity.
Yes.
So, CAR T cell therapy, it comes into which form of?
It is what we are calling as the adaptive immunity. So you have got the adaptive immunity and the innate immunity within the body. So adaptive immunity is your B cells, T cells. So this is where you are reverse engineering a particular T cell to start proliferating against the cancer. So it is a form of adaptive. So it will be against your what you call as adaptive immunity.
So same is for stem cell therapy?
Stem cell therapy is also a form of immunotherapy. Only thing is it is much more crude in that sense that you are taking somebody else's stem cells your HLA matched stem cells and putting it within your body.
I want your one line for autologous blood transfusion. Is it used for any treatment or
I think autologous blood transfusion surgeons are doing it before any surgery.
or for even enhancement of performance like athletes?
Yes. So athletes are doing it on an illegal basis.
Thank you, sir.
I'm sure there will be some questions on the first talk. I'll go to Dr. Padar, sir.
Thank you, Dr. Mishra, for an excellent lecture. One of my relatives was diagnosed Rojae-Dorfman disease. I think it's a rare disease, but so he was on steroid, but he still regularly gets fever. He has to take continuous steroid. He was tried rituximab also, that didn't work. So any other drug, new drug in Rojae-Dorfman disease?
So currently there are no new drugs. You do give chemotherapeutic kind of drugs, like you give rituximab, you give chemotherapy, you give methotrexate. So you try. It's basically Rojae-Dorfman is more of a proliferatory disease. It's at a gray zone between a malignancy and a non-malignancy kind of disease. Generally considered to be benign, but you can use chemotherapeutic drugs in those patients. Even radiotherapy is used where there is much proliferation, but there are no new drugs per se. Thank you.
Dr. Savita Sachdeva ma'am, herself an eminent pathologist in CR Park. Sir, she would like to ask a question.
The same thing applies in multiple myeloma and this antibody treatment will work there also?
Yeah, so multiple myeloma previously was all chemotherapy. Now you've got monoclonal antibodies. Like in CD38 is there on all plasma cells. So you've got CD38 directed cells, there is direct movement. So that is extremely useful. And those patients who are not responding to that also, you've got CAR T cells which are against BCMA. Now BCMA again is an antigen on myeloma cells. So yes, we have got immunotherapy and adoptive cellular therapy for myeloma.
Thank you.
Dr. A.S. Nigam sir has a question. Yeah, I'm coming to you. Dr. A.S. Nigam sir.
Hello. Dr. Pravas, it was a wonderful lecture and I'm happy that he happens to be from my alma mater, almost 20 years junior to me. So, excellent talk.
Thank you.
So, I just want to know about your MRD. So, you may be doing by flow cytometry?
Yes, sir. So I did not show that slide for lack of time, but otherwise, MRD initially was what? You just look at the slide and say whether the person is still in remission or not. That was the earliest MRD that you did.
Yeah.
Then after that came flow cytometry.
Yeah.
So that is 1 in 100 cells, 1 in 1000 cells.
Yeah.
And then you have got molecular, that is polymerase chain reaction. So if you have a molecular target, then you do that, that is even more sensitive, 1:10⁻⁹. And now we have got NGS.
NGS.
That is next generation sequencing.
Yeah,
So that is,
NGS of course may not be available at many centers.
yes, but now, this all started with your human genome project. And now you know that it is very cheap to even get your own whole genome to be mapped. So there are centers which can do your NGS in about 14,000 rupees. So there are almost every big hospital in Delhi now has its own NGS machine. So it is very easily available and it is very sensitive and almost all your patients will have some molecular target or the other that you can do MRD.
Okay. And second thing I just want to know about your post-chemotherapy febrile neutropenia.
Okay.
What is the problem you face post-chemotherapy?
Yes, sir. So chemotherapy, like the traditional chemotherapy we do, like acute myeloid leukemia, lymphoid leukemias, even solid malignancies, febrile neutropenia is always a problem. So we first tell and educate our patients that you have a fever, you immediately come to the emergency, and our target is, the needle time from the patient who comes to the emergency, within 20 minutes they should get an antibiotic. Intravenous antibiotic. So you draw blood cultures, paired blood cultures, aerobic culture, urine culture, and you immediately put in some broad spectrum antibiotic depending upon the culture sensitivity in your particular institution. In my institution in Amrita, my go-to drug is still cephalosporin sulbactam with amikacin. But some center, if it is there, then it is better to give meropenem. So febrile neutropenia is still a problem, not just in chemotherapy, even in transplant, CAR T-cell therapy, everywhere you can have this problem.
So you rely on blood culture, or are you doing some parameters?
Yes, so we now
procalcitonin or
so procalcitonin and all are good when you are doing this transplants. So because fever can be because of a drug also. So you do procalcitonin, you do CRP, serial CRP to know whether this person.
HSCRP.
But cultures are still our go-to molecule. In sputum or bronchoscopic alveolar lavage, we now do PCR based. We call it biofire. You might have all heard of biofire. Within 3 hours, you will get a result whether your person has a bug or not, and also the sensitivity pattern.
Thank you, sir.
Dr. Sarat Gopalan, who is a pediatric gastroenterologist. Please come here, Dr. Sarat. Dr. Sarat's father was the Director General of ICMR. He lived beyond 100 years. He was also the founding president of National Institute of Nutrition, Hyderabad. Dr. Sarat Gopalan happens to be the president of Nutrition Society of India at present. He has a question.
Thank you, Dr. Sushil, for those kind words. Dr. Pravas, it was a wonderful presentation from your standpoint. My question is, I am a pediatric gastroenterologist. In active practice, I am associated with the Rainbow Children's Hospital. And I have been associated for several years, ever since it started. It's a new hospital, but it's standalone. My question is, from the standpoint of the association between celiac disease and leukemias, which is quite well known. So, adult versus pediatric, CLL, CML, AML, ALL. We have 4 different leukemias. Which is the most common, acute or chronic? If it's acute, is it ALL or AML? If it's chronic, is it CML or CML? CML or CLL? With celiac disease, adult versus pediatric, is there a huge difference or is it comparable?
So we are talking about celiac disease between adults and pediatric first?
No, sir. He is saying, is there any? First of all, is there any relationship between celiac disease and leukemias? And if it is there, then is it more strongly correlated to acute or chronic?
So many such chronic inflammatory conditions have got a good association with malignancies. Association. You cannot say causation. And if at all there are some association, it will be with the chronic lymphomas or the chronic leukemias that are there, not with the acute. Even like rheumatoid arthritis, chronic rheumatoid arthritis, people have, there is an association with lymphomas. So that is there. But again, it is an association.
Dr. Jitendra Saxena, who comes from a family of doctors, my batchmate from 1979, his brother, Dr. V.K. Saxena, is an oncologist, and his brother, elder brother, Dr. R.K. Saxena, an ex-M Sonian, you might be knowing him, Dr. R.K. Saxena. He is a urologist and a transplant nephrologist now in Jaipur. He has a question.
Sir, my question is out of the 4 leukemias. In fact, my question was partially asked by Dr. Sarat Gopalan. So just wanted to know which is the leukemia which will respond best to bone marrow transplantation and the leukemia which will respond best to the targeted therapy.
So mostly when we are broadly speaking, I mean that will be an entire lecture in itself, but chronic leukemias will be more for targeted therapy. Acute leukemias which are fast growing, which are supposed to be curative but have good relapse rates. So those are the patients where you will do more with allogenic transplants. But having said that, you could have interchangeability also. So like I initially started with targeted therapy was for acute leukemias. And then we go to transplants. Mostly allogenic transplants would be for acute leukemias. But again, you could have like multiple myelomas, lymphomas where it is mostly autologous transplants which are being treated.
Sir, if someone is to get leukemia, which type of leukemia he should get?
Somebody should not get even common cold. So common cold will not hona chahiye.
He wants prostate cancer to be choice.
No, he saying leukemias.
Choice तो कैंसर की है तो फिर prostate cancer वही आने दो.
But if you have to get a acute leukemia, then maybe I should get acute promyelocytic leukemia because it is 85% curable in an adult patient.
Sir, of course the prognosis is much better these days, but I have seen patients who were diagnosed with leukemia in 80s and 90s and doing well still.
Absolutely.
They are still living. They have not gone any transplant, bone marrow transplantation or targeted therapy. With the therapy that was available previously, they are doing so very well, sir. 30 years, 40 years, not one, many.
Absolutely. Sir, I will not go into the specifics of individual leukemias, but you know in statistics there is this thing called a bell curve. Everything is in the median, and then you will have patients on either side of that curve. You give even placebo, there will be some who will be surviving long, and you give the best of treatment, there will be some who will be only surviving 6 months.
Dr. Pravas sir, Dr. M.P.S. Gandhi, our ENT colleague, our elder from Charakpalika Hospital, ex-CEO of Charakpalika Hospital. Sir, he has a question and he has always very good questions for us.
Sir, how important is the storing of cord blood for the newborns for the treatment of CML or aplastic anemia to that particular child or even to their siblings in future?
Cord blood is an extremely important source of stem cells. It is an extremely important source of stem cells for allogenic transplant. That means you have got this public cord blood banks where you donate the cord blood of your newborn baby and it is kept in, you do the HLA testing. And if somebody gets a leukemia or an aplastic anemia or any condition where you want to do stem cell transplant, that cord blood can be used. But it is not going to be useful for yourself or for that child also in future, because it is like doing an autologous transplant, no? So if that child is developing aplastic anemia, what's the point of giving their own cord blood? And it may not be useful to any family member also. It should be, so this targeted cord blood or where you are paying for storing your own cord blood, that is not, I am sure there are gynecologists in the audience, it is not approved by Foxy. So what they do is a different kind of, I think, a financial model now. Now what they are saying is that whoever you have put your pool of cord blood in that bank. If anybody in that particular pool who have done, in that pool gets some kind of malignancy, and if he or she gets a match within that pool of cord blood, can get it. That is different, but otherwise it is not useful. They say that you can reverse engineer your stem cells, but for that you don't need cord blood. If you master, there is reverse engineering of stem cells to become pluripotent stem cells, you don't really need cord blood for that.
They are storing it for 75 years or so, and they claim in future if something happens.
Yes sir, but that future has been, right now that is not there.
Sir, you gave your DM exam long time ago.
Yes.
You will be reminded.
Refresh.
No, so Dr. Mishra, let me say some very simple questions to ask you.
Yes sir.
So once again, a very nice talk. So, Dr. Mishra.
Before that, whenever I listen to your simple questions from the videos that you put out, I'm getting very frightened.
Let me proceed, sir.
Yes sir.
So, within the world of oncology, or can I say hematological malignancies, cure is a very tricky term.
Yes sir.
Functional cure versus actual cure. What do you say, sir?
Absolutely right, sir. So when we talk of cure, we always want actual cure. That is our target for many of our malignancies. But when we are talking, for example, let's say myeloma, there I am talking of a functional cure. That means the person is not cured of the disease, but the disease has become chronic. So I keep telling them, my aim is to make it like a blood pressure or a blood sugar. So the disease is there somewhere in your body, but let's forget about it. You take some medicine and you do that. So the functional cure, to my mind, is actually not a bad target.
So to extend Dr. Savita's questions regarding multiple myeloma, it's not curable, but can be managed very effectively with the newer immunotherapy drugs, CAR T-cell drugs, etc. And talk us a little about the minimal residual disease, which is known as the MRD.
Yes, sir.
So, are you doing multiparametric flow cytometry, qPCR, NGS for a complete cure?
So we do all of these techniques not just for the complete cure, even for the functional cure as you mentioned it, So we do all the techniques, whatever is available to us, we will use it. So if we have got NGS available for a particular malignancy, we will use that.
Wonderful, sir. Thank you, sir.
I think we had the first wonderful session over, question answer session over. Sir, you did a wonderful job, Dr. Pravas, and my wonderful moderator, Dr. M L Kalra, sir. I would now invite questions for the second session, and I would give the mic to Dr. Bhaskar Shukla to set the context and the ball rolling for questions and answer sessions on movement disorders, specifically directed to Parkinson's disease, specifically focused on botulinum use and deep brain stimulation. Dr. Bhaskar.
Thank you, sir. Sir, it was a very excellent talk, and best of all, it was very crisp and before time. So, sir, very splendidly explained the role of botulinum toxin and the DBS in various movement disorders. And simply put, basically, botulinum toxin is basically peripheral intervention, and DBS is a central neuromodulation. So they have different indications, but in the same patient, the same given patient, at times both the interventions might be useful. For some conditions, the same patient, this botulinum toxin can be helpful, and for others, DBS can be helpful. Although it's rare, but yeah. So there is no watertight compartment where we should use DBS and where we should use botulinum toxin. As sir rightly said, it started, the use of botulinum toxin started with the cosmetic use, but now it has countless number of indications, ranging from the movement disorders to whatnot, like epilepsy, like whole lot of dystonias and tremors and etc. We can use it for sinuria also, neurogenic bladder also. So there are many conditions in which the botulinum toxin can be used. Spasmodic dysphonia we can use. And DBS also has an ever-expanding list of indications. Traditionally, it has been used most commonly for Parkinson disease, levodopa response. Parkinson disease, especially when the patient develops drug-induced dyskinesias, levodopa-induced dyskinesias, then it is the time when we should give this option to the patients. But sir, in your practice also you must have experienced that the convincing is the most difficult part as far as DBS is concerned.
Yes, so you need to be very honest with the patient. And that is, you should not do DBS before it is indicated. Like I get many patients who have Parkinson disease and they say that can the DBS be done today? No. If you do DBS in the first 3 years, you are likely to commit a mistake. Because what will happen, many of the patients may not be Parkinson disease. Those patients may be PSP, or those patients may be MSA, or in this area SCA12 is very common. And SCA12 is more prevalent in Agarwal population, but many times they come as a Parkinson symptom. And in first 3 years time, if you do DBS for Parkinson patient, you are likely to land up in trouble. So your selection of patient is very important. Like you said, that when the patient has motor fluctuation, patient had levodopa-induced dyskinesia, then you start looking about that. And like currently we are doing one DBS every week, and most of the patients we are able to convince. The reason is that our selection criteria is very robust and very, very stringent. And that is the reason the patient brings patients, and if your selection criteria is correct and if your approach is honest, then your results will be good.
So besides Parkinson, what all indications you have?
So we are primarily doing Parkinson and dystonia, but we have done a couple of palliative, like a young boy from Lucknow, we had very severe chorea, and we did for Huntington patient, one patient. Another patient we did for tie-dye dystonia. Tie-dye dystonia is very good response, but if the tie-dye dystonia is focal, then you should always start with botulinum toxin, because they do very well. But sometimes it happens that tie-dye dystonia is generalized, then botulinum may not work. And those are the patients where you should think of doing this. Another patient we did was NBIA, because in NBIA the results are good for first 5 years, but since the disease is progressive in nature, then you have to tell the parents very carefully that look, this is not curative. Maybe the dystonic symptoms may be improving, but the disease is likely to progress. So you have to do an honest conversation to the patient, and then you can go ahead.
1971, before I entered my medical school. So we came to know about it maybe 3 decades or 4 decades later. So have you ever used antidote for Botox like pyridoxine in your practice? In any case, has it been required?
So if your selection of muscle is good and your dosage are optimal, then it is not required. The only thing is that in some time in pediatric patient, you should not inject less than 2 years of age, and the dosage should not be more than 10 units per kg. Because if you inject more than 10 units per kg, the child may develop respiratory paralysis. So you need to be very careful in pediatric patients.
We have not used antidote for it.
We have never used.
It's a wonderful presentation on movement disorders, and since the time was very short, you utilized it beautifully by showing some videos and the best carry home messages. My question is on the Parkinson's itself, sir. And when we start treating Parkinson, we start with Syndopa, as you said, sir. We start. Yeah, भाई आपसे बात कर रहा हूँ. When we start using Syndopa, we start using the plain doses, and then we use an optimum dose of Syndopa. At times we start with 6 hourly, then 4 hourly, and then we use CR dose. But after a certain time, it doesn't give the desired results, and we go to the other molecules. One of those molecules is propranolol for tremors. There was an introduction of a molecule called amentrol long ago. Is there any role of that now these days?
Yes.
Or because of cardiac arrhythmia and other issues it has been withdrawn? Your view on that?
So like you rightly said that Syndopa is the gold standard treatment, and patients should be treated by Syndopa. One thing I would like to clarify very clearly that physicians have tendency to delay Syndopa. मत दो इससे आगे चल के दिक्कत आएगी. That is not correct. Your therapy should start with Syndopa, and your therapy should end with Syndopa. Syndopa is the most important drug. Regarding amantadine, it has a role when the patient start getting levodopa-induced motor fluctuation or levodopa-induced dyskinesia. Why it happens? Because there is a receptor for binding dopamine. So as the disease progresses, the receptor gets degenerated. So the amount of levodopa you are giving, the receptors are getting sensitive. So now the effect of levodopa is reduced. Initially it was 4 to 5 hours. Now it is only 2 hours or 2.5 hours. But at the cost of dyskinesia, like you saw that patient who was just dancing because he has a low levodopa-induced dyskinesia, their DBS is very good. But if the patient cannot afford DBS, you just reduce the dose of levodopa and add amantadine. Amantadine is a very good drug for that stage because it controls dyskinesia very well because the pathway is NMDA mediated. So it's an antiviral drug, but it's a very well proven drug for levodopa.
Sir, any dose of Syncopon, Encapon?
Yes, so Syncopon is a good drug if the patient has a motor fluctuation, like the effect is wearing off very early. Because if the effect is only 2 hours, 3 hours, you can add Entacapon with levodopa, that is Syncopon. So what it will do, it will delay the metabolism of levodopa and it will increase the duration of effect from 2 hours to 4 hours. But one caveat is, the Syncopon may lead to some off effect, like the effect of levodopa may not come because the metabolism has been slowed down. So if you are introducing Syncopon, you should be very clearly telling your patient that look, if you don't get any good effect of the drug, maybe you can discontinue it.
Sir, DBS has proven itself to be a very effective therapy.
Yes.
But we have often been told that there is a cut-off age for it.
Yes.
Some centers say 65, I heard a neurologist saying, no, you send a patient to me, 75 years, I will do it. So what is your cutoff in Amrita? And if my patient has been well controlled on Syndopa and Syndopa-CR combination with Singapore and Capone combinations, now, and he's 86 years of age, but at this point in time, he has his off phenomena with the medications, and he says, Doctor Sahab, हमें किसने बताया operation होता है, ठीक है? Is he a good candidate for DPS or no?
Yes, so the cutoff, what our science says, is 75 years of age. 75, beyond 75, you should always think if the DBS is indicated in this patient. The reason is that many patients have cardiac comorbidity, many patients have cognitive issues, many patients have some heart-related issues, many patients have some like other comorbidities like osteoarthritis or something like that. But if you go to United States, people are getting DBS at the age of 85 also. The reason is that we are living in a joint family. If the family is small and if the patient wants to get independent and there is no comorbidity, maybe the DBS can be done after 75. But you should always think yourself that is the DBS indicated if the age is more than 75. You need to be very honest about that. But yes, in some situation you can go ahead if the patient is fit and fine and you think that patient can go ahead with a surgery, there are no comorbidities, but usual age, cutoff age is 75. We usually don't cross that.
Dr. Ashish Verma has a question.
So my question is asking you that when you are saying that what's the difference between a functional cure and an actual cure? When like a patient of Parkinson, you won't have any specific test for it that can say that okay, you do this test later on and then you can find out that there's been improvement and all. So if there's an improvement in the condition of the patient with any treatment, like I'm doing stem cells and I'm seeing that patients are getting much better. So then how can you say that it's only a functional cure and it is not an actual cure?
No, so the functional cure and actual cure means that currently there is no therapy which can basically halt the disease progression because it's a neurodegeneration, and because of the neurodegeneration the dopaminergic cells are dying and that is leading to a manifestation of Parkinson's disease. So whatever therapy is currently available, be it medication, be it DBS or be it anything else, it is not able to halt the disease progression. And that is the reason there is an ongoing neurodegeneration. We are able to give symptomatic therapy to the patient, be it DBS or be it medical, but the disease is still progressing. So that is the reason I said that there is no cure, but there is just a symptom.
Dr. Gandhi sir has a question.
Sir, how early DBS should be started to a patient and what will be the initial cost and recurring cost in future?
Yes, so the DBS, like I said, that should not be done before 3 years of age of the diagnosis. Suppose the patient has a Parkinson's disease at 65 and till 68 patient is doing well on levodopa. If the patient is developing motor fluctuation or dyskinesia, like the drugs are, duration of effect is now less. Initially it was 4 to 5 hours, now it is only 2 to 3 hours, or the patient is getting dyskinesia. This is the patient which is a case for DBS. Coming to the recurring cost, there is no recurring cost. There is a one-time cost, and the one-time cost, like there are rechargeable battery and non-rechargeable battery. For non-rechargeable battery at our center, the cost, all-inclusive cost is 13.5 lakhs. And that includes the cost of the battery, 7 days hospitalization, MRI, and first 1 month of programming. The cost of recharge and the life of non-rechargeable battery is 9 years, 8 to 9 years. That is preferred if the patient is 65 or 70 years of age. But if the patient is young, like if the patient is 60 or the patient is 55, we go ahead with the rechargeable battery. Or the patient is dystonia, because the dystonia requires more battery. We go by rechargeable because the rechargeable life is 15 years, and the cost of battery and surgical cost, there are 3 types of battery. One battery without directional lead, one battery with directional lead, one battery with AI features. So if you take the range, the cost will be 15 lakhs to 22 lakhs. But you can go ahead with the patient, you can give the options to the patient. but the 15 lakh battery also works very well. And the cost at our center is, I think, it's the cheapest.
Very less, I think.
Very less.
In other places it is 25 to 30.
Yes. So our cost is just a little bit higher than AIMS because we just include the cost of the surgery and cost of primary admission.
Dr. Sunil Kapoor sir has a question.
Yes.
It's a very small question. That at around the age of 75 or so, you can lacunar infarcts and all that. Won't it distort the architecture of the brain and therefore disturb the wiring and all this?
Yes, so if you before doing DBS, we always do MRI just for the trajectory, and if the patient has a lot of lacunar infarct and if the cognition is also getting affected, that is not the good candidate for DBS. But if there are some just periventricular white matter changes, cognition is good, then we can go ahead with the surgery. But definitely there is a Metis dementia rating scale, and we follow that. If the cutoff is less than 100, then we don't go ahead with the surgery.
Thank you, sir.
I give it to Dr. Tulsi to ask the last question. He has promised me to wind it up in 1 minute.
Thank you, Dr. Pandey. That was a nice informative talk. So, to extend Dr. Chauhan's question regarding, age limit, I believe there is no age limit. If the patient does not have significant dementia, so if the patient has dementia, this is contraindicated. And having said that, what about the latest, I'm forgetting the name, which is, let me recollect, it is the closed loop DBS with real-time monitoring. So is this available? Is it coming? Is this the future?
Yes, this is available, and the cost of the battery is 19.5. And the cost of the surgery will be 22 lakhs.
So this is personalized treatment?
Yes, so what happens that you can monitor the LFP, and LFP is long frequency potential, and it guides in programming. So programming becomes very easy with that. So if the patient can afford the cost, then we can go ahead with this device. But that device is available for last 6 months, and we have been.
My last question would be regarding MRI guided focus ultrasound. Is there an alternative to the DBS?
Yes. So MR guided focus ultrasound is a good therapy if the patient has only tremor, like we see in essential tremor patient. You can do thalamotomy and the patient tremor is better. But it is not a good treatment for patients who have bradykinesia, who have rigidity, or who have leukodystrophic dyskinesia. Because in Parkinson disease, the disease is likely to progress, and that is a lesional surgery. In DBS, it is not a lesional surgery. You can modulate the programming, but in focus ultrasound, you are making a lesion inside the brain.
Right. So as Dr. Bhaskar Shukla said, this is not going to arrest the progression of PD.
Yes.
This is just to control the motor symptoms. Apart from this, as Dr. Chauhan said, so drugs, medications would cause this kinesia. This probably would take care of that. Thank you, sir.
Thank you.